Hello and welcome. We're glad to have you joining us today. Before we get started on our CQ and Health Equity webinar, I'd like to start by noting a few housekeeping items, and you'll see some of these on your screen as well. This is a webinar, so you are on mute and your cameras will not be shared today. I'd like to take a moment to introduce our session administrator today, Ms. Prudence Anglum. Prudence will be able to answer any of your questions throughout the session. Feel free to use the chat feature to get in touch with her regarding any technical concerns, etc. Additionally, feel free to use that chat feature throughout the session to engage with the content and ask questions of our panelists, who I'm going to introduce here in just a moment. Please note that we will save 10 to 15 minutes of time at the end of today's session for questions from the audience. So what are we going to cover today? We're going to cover some important topics about cultural intelligence and how that relates to health equity by focusing on things like what are some of the main challenges in healthcare and with health equity? How can we leverage cultural intelligence or CQ to navigate those challenges? We'll talk a bit about resources and advice available to help facilitate these discussions. And we'll talk about what better patient care can look like when health systems invest in the development of the cultural intelligence of their people. Now I'd like to introduce you to our panelists today, Dr. Ana Pujols-McKee and Dr. Devan Ford. Dr. McKee, who has asked us to refer to her today as Ana, is former Executive Vice President, Chief Medical Officer, and Chief Diversity and Inclusion Officer for the Joint Commission. She also served as interim CEO for the Joint Commission. She's a healthcare executive with over 25 years of distinguished leadership experience in healthcare. Throughout her career, she has successfully provided leadership in a broad range of healthcare settings, including academic and public health systems, the insurance industry, integrated healthcare systems, and with the nation's largest quality and standard setting organization. Throughout her career, Ana has been the recipient of numerous industry distinctions, including top 25 minority executives in the nation by Modern Healthcare in 2014, and 2020, the Modern Healthcare's 10 to Watch Top Diversity Leaders in 2022. Dr. Devan Ford, who has asked us to refer to her today as Devan, has over a decade of experience in diversity, equity, and inclusion, with a special emphasis on gender equity and unconscious bias. Devan has a background in higher education and previously served as senior DEI leader and faculty member at the University of Houston. In 2019, Devan joined MD Anderson as program director and DEI practitioner, focused on providing DEI education, training, coaching, and consulting to the MD Anderson workforce. Additionally, Devan holds several training certificates, including cultural intelligence, which we'll talk about today, restorative justice and academic medicine, unconscious bias, diversity and inclusion in the workplace, interpersonal communication, and more. So now that we've introduced our panelists who both have a wide range of experience, let's go ahead and get started with our first question today, which I'm going to pose to you, Ana. Let's start by talking to our audience today about health equity. Can you define for us what health equity is and where you think our current health system is in terms of achieving health equity?
Great. Well, first I want to thank you, Kayla, and tell you and Devan, it's great to be here with you this morning. So healthcare equity lives under the umbrella of quality and safety. It is what we do in healthcare. It does not live outside. It's not a separate entity. It's not a separate problem. It is a quality and patient safety concern. And I define healthcare equity as healthcare where you achieve optimal outcomes that are disencumbered by bias, discrimination, racism, institutional racism, and all of the isms that we've spoken that have come to the forefront. What healthcare equity is not is the acceptance of quality outcomes that have variation because of a person's color, sexual expression, language, or any other difference that that person presents. We are looking at an opportunity now to look at the definition of quality and safety in a completely different way. And that way means that we remove those barriers that have been either invisible or visible and acceptable, that we begin to treat and provide care in a completely different way. I find it totally appropriate to classify healthcare equity as important as the reduction of a ventilator-associated infection or a central line infection. It is as important and as critical. So I will stop there with my definition, and I don't know if Devan wants to add any more to it.
Thank you so much, Ana. That was a great start. I don't have anything to add to the actual definition. I think you really encompassed it, but I do want to go back and highlight and just reemphasize the piece that you said about quality and safety and not thinking of healthcare and health equity as something that's separate from that. I think that is just incredibly important to be able to recognize that, and that can also help to people to understand how critical it is. I also want to just point out social determinants of health, and I think understanding and addressing social determinants of health, which are the conditions and environments where people are born, where they live, where they learn, where they work, where they play, where they worship, where they grow older, and so on, really is going to help us to understand health equity too, and help us to understand those issues that are impacting that and the work that we can do. But I can't reemphasize enough that quality and safety piece. That's so important to see it, as a part of that and not something that's totally separate.
Yeah, I appreciate both of your input there. And I like how you both defined what is it and what is it not, right? Ana, where do you think our current health systems are in terms of achieving health equity?
Well, the answer is all over the place. In my experience, I've worked with organizations whom we should really be learning from them. They have been progressive. This has been on their agenda for years, and they've done remarkable work. But unfortunately, I've also spoken to executives of healthcare organizations whose response is, what are you talking about? This does not exist in our community. We don't see color. And they are far, far from beginning to take the responsibility that they should for any kind of quality and safety concern regarding health equity. So the answer is that we have a spectrum of engagement and awareness, understanding of the problem. And but this is not different than any other new or emerging healthcare problem. Not everybody gets it the first time or gets it and chooses to approach it with the same vigor. So it's not new. It's just that we have to have multiple conversations. We have to be learning from the organizations that are doing very well, while at the same time, we have to be pulling organizations that are just beginning to creep or crawl on this topic and need a lot more information and support.
Yeah, that makes sense. Of course, not everybody would be achieving the same outcomes at the same time. For those institutions that perhaps aren't as progressive or who haven't maybe started on their initiatives and have furthered them as many other institutions have, what are some of the challenges that are prohibiting that we still need to address so those institutions can move forward?
So I think the organizations who are on the far left or the beginning of awakening kind of level, some want to awake and some want to just really do want to address the issue. The problem has been not visible to many healthcare leaders because of the lack of the data and how we look at our outcomes. Most organizations do not drill down to specific groups and look at how their marginalized communities, the outcomes they're getting compared to other groups in their community. So the awareness is impaired by the fact that the data is not there. Now, there's a lot of work that's being done on the data, and there's also an opportunity for organizations to begin to look at some of the Joint Commission's new standards that are actually requiring them to collect the data and to select a topic that is relevant to the community that they serve and to begin to address it. I think the one thing that's really was thoughtful about how the Joint Commission approached this was it didn't say fix everything. It says start here. Yeah. Start by collecting data. And that data, once you look at it, is going to open up your eyes to see an opportunity that perhaps in your community, the Native Americans and the African Americans and Hispanics are coming in with far advanced complications of diabetes compared to everyone else. Why is that? And those are the kinds of questions that those new standards are designed to get organization leaders to begin to query their data and look for those opportunities and to start. Yeah, to take action.
That's really insightful. And I know that you are a big part of setting those standards to make sure that measurement and that review of the data happens. Devan, would you add anything to what Ana said about some of the challenges that are impeding us from moving forward in this work?
Going along with what she said, I think the other piece to consider is it can be very difficult for organizations. We talk about healthcare institutions and organizations to admit that they have the issue, right? So you collect the data, you analyze it. I mean, you may be able to identify, who's being excluded, where you need to put more emphasis, but then what do you do with that if you haven't been able to start yet? And so I think that accountability piece is so important, being honest about where there is lacking where those are opportunities for, changes. And then I think that benchmarking piece, as Ana mentioned, and looking to those healthcare organizations and institutions that are more progressive for their practices, for their strategies and initiatives. And I think that the way that the Joint Commission lays it out, as Ana mentioned before, with, start here, I think
Yeah.
that is a great place to start. But it takes people being honest about where they are in terms of, their organization and that accountability piece.
Yeah. Yeah, that makes sense. Let's move into another piece of this. Part of achieving that health equity, as it was described to us, includes ensuring patient and caregiver relations are strong, effective, and really importantly, that they're culturally appropriate. How important is onboarding and training to achieve health equity? Let's start with you, Devan, for this one.
So many thoughts on this one. I'm going to try to narrow it down and keep it
Okay.
concise. This is really the area that kind of gets me going or charged up. But that's a great question, Keyla. Onboarding and training, they're really critical to achieving health equity. So if we think about effectively serving our patients and providing, care that's appropriate, that's culturally responsive and respectful, it really starts with that onboarding and with that training piece. So, all employees across a healthcare institution, those who are direct caregivers, have patient-facing roles for sure, but even those that don't, because we think about peer-to-peer relationships, right? We think about a total cultural aspect and cultural transformation within our organizations. That onboarding and that training is going to be critical for every single employee. So starting from the time that you begin, your employment, I think about at MD Anderson Cancer Center when I started back in 2019, the first thing that you do in terms of onboarding on day one for every employee is go to an onboarding celebration. And we call it a celebration instead of a training. That lays that foundation to really understand the values, of the institution and the organization, to really understand the culture and the expectations. So throughout that full day of onboarding, we were told over and over and over again at MD Anderson, caring is a core value, safety is a core value, and a big part of the focus of that is inclusion. And that includes for us competencies of cultural intelligence, cultural humility, and cultural awareness. And so it is expected that these are going to be things that you will become well-versed in if you are not already. And then from that onboarding piece, which is that baseline, you go into that training and you continue to be trained. And it needs to be relevant to the job or the task that you have. So certainly there may be different training related to, cultural intelligence or cultural humility, multiculturalism, understanding your own backgrounds for people, again, who work directly with patients than those who don't. But it's going to be, critical to start and continue that training throughout the course of a person's, tenure at that particular institution. I'll also say that training is going to have to be delivered in a variety of ways. So we know that our working environments are different. We know in our healthcare, systems and organizations, we have folks who work overnight. We have folks that are hybrid, those who are remote, those who are inside, the hospital or inside the offices every single day. And so delivering that in various methods, like having hybrid trainings, online courses, facilitator-led sessions, independent modules, self-assessments, also really important, but then having the debriefing. So you don't just take an assessment and get results, but what does that really mean? And I love the way that, even the CQ, the 360 assessment does that. So it allows you the opportunity to see where you are in terms of your own cultural competence. That piece is important. And then I think you have to have spaces for your employees to be able to just openly dialogue and share, to be able to say, I'm facing this challenge as it relates to understanding maybe this aspect of diversity or these experiences that my patients have had and that they're coming in with, but they're not my own experiences. They're not parts of my own identity, but how can I, learn more, meet them where they are and still support them? So you have to have those safe spaces for that dialogue and conversation. for employees to be able to say, this is unknown to me, how can I know more? And for them to be able to pose questions as well. So it's not just, the training and the learning environment where you go through the training, but it's also critical to continue those conversations and have those dialogues that can sometimes be challenging, but can lead to that better awareness, that better understanding. And then I'm also always going to be an advocate of being practical in terms of the knowledge. So having simulations, having opportunities to put into practice what one learns, and then, continuing to assess that over time and figuring out where continued development needs to take place, where people are doing well, getting that feedback from patients, from their family members and caregivers is going to be critical too. So constant feedback loops and assessment and evaluation of how the training is really being put into practice and the experiences that patients are having are going to be really, really essential. And then the last point, then I need to wrap up. So Ana can have a chance to go. But the last point I want to make is just taking proactive approaches instead of being reactive. So I know we saw through 2020 and 2021 after the murder of George Floyd, and then this highlight that we had of health inequities and health disparities due to the COVID-19 pandemic, that propelled a lot of healthcare institutions into action, and that was a good thing. But here we are 3 years later, where are we now? What do we need to continue? What do we need to stop that's hindering our ability to keep this going? And then, what do we need to figure out in terms of the gaps that we have in our education and in our onboarding and be able to address those?
Yeah, that was such a rich answer. And Ana, I have a follow-up question for you. But first, I like the reoccurring theme that I heard there from Devan is we can't consider onboarding and training a once and done thing. It doesn't work like that. You can't go learn a new concept and automatically behave differently. You have to make safe spaces for people to practice the new concepts that they've learned. Make sure there's accountability to reinforcing the topics that were discussed, not once, not twice, but throughout the longevity of the employee and the staff and the patient's career at the institution. So that was just really a rich response. Thank you so much for that, Devan. Ana, I'd like you to add to what Devan said, but very specifically, I'd like to ask if you have any advice for our audience about how could they start a dialogue about the importance of this type of onboarding and education with their own leadership. So go ahead, please.
That's a great question, and it helps me incorporate some of the richness of what Devan shared with us. First of all, Devan, I love the idea and the way you use the word. We don't call it training, we call it celebration. Yeah. And that goes to the fundamental change that organizations need to make, that this is part of your values of your organization. It has to be reflected in your vision and your mission statement. It has to start there. It has to be core. And the core value is that we celebrate our diversity, and that diversity helps us treat one another better and take better care of our patients. And that's the bridge between healthcare equity and diversity, inclusion, and equity. They are all intertwined and they all drive one another. And so I love the way Devan used the word celebration, because it is a celebration. Yeah. And the celebration, the process of celebration is an educational process. Yeah. Where you share and you learn about our differences. And again, we go back to that celebration. Those differences are to be celebrated and they bring value to the organization. So to the core question that you asked, Keyla, about where do organizations start, they have to start at the very, very top of the organization, and that's with governance. And the quality and safety leadership of the organization has to make it clear to governance that under the umbrella of quality and safety, and under the umbrella of the governor of the trustees, oversight of the organization is healthcare equity. The governing body cannot choose to say, we're not going to care about urinary tract infections. We're only going to care about these other safety things. You have to have accountability according to the law, which are Medicare conditions of participation, that the governing body has oversight of the quality and safety of that organization, and that quality and safety includes healthcare equity. That's the first step of where an organization starts. Hopefully that leads them to making sure that their organization's mission and value and all of those important documents reflect that commitment, so that when the next CEO comes, it's not, oh, I have a different idea. No, these are the values of the organization that are approved by the governing body, and this is how we march forward. The second thing, and I encourage organizations, even though there's been much variation around the country, is try not to build a different infrastructure. Again, if it's quality and safety, it belongs under the talent and the expertise of the individuals who are responsible for all outcomes of the organizations. And I say that because the argument is, if you build a completely different structure, the moment the finances get difficult, guess what goes? And so if it's incorporated and built in, I'm not saying don't invest. I'm just saying integrate it. It is part of the infrastructure, quality, and safety. The other reason I say that, because some of the fundamentals around how you approach any quality and safety concern is that you identify the root causes of why you have the variation. And if we do not do that when we're trying to address healthcare equity, we're going to have missteps. And that root cause requires an organization to create a trusting dialogue with that marginalized community. You cannot say, oh, I see the problem, I'm going to fix it, and I have the solution. You cannot do this to a group of people. You have to do it with a group of people. And so having that quality and safety, fundamental approach to quality and safety is one of the essentials in addressing healthcare equity. And then having measurement, because if you don't have the measurement, again, it's going to be a lost effort, and having that data. The education piece is important, making sure that you're cycling back, that you're bringing up the level of empathy, understanding, and inclusion of your healthcare workforce. And lastly, that community engagement is a completely different way of working with communities. And I mentioned it's not what we do to them, it's what we do with them. And that is really a different way. It means bringing people to the table and understanding the issues at a much deeper level. So that's kind of the major approach that I would recommend organizations to take.
Yeah, that's so helpful. And I think that, this idea, as I lead into our next question, I'd like to pause just a moment so that I can define what is cultural intelligence, because one of the things that we keep hearing from both Ana and Devan is the importance of measurement. Right? And you heard Devan share a little bit about using things like self and 360-degree assessments to measure our current or benchmark our current capabilities to do some of these things that we're talking about. So what is cultural intelligence? Cultural intelligence is the capability to relate and work effectively with people who have different cultural backgrounds from our own. It's not just what we know about each other, it's how do we think differently? How do we behave differently? How do we make appropriate judgment calls depending on the cultural situation? So, Devan, you are certified in cultural intelligence. Can you talk to us a little bit about what is it about CQ or cultural intelligence that you have found can help us navigate some of the challenges that we've been talking about so far?
Sure. So the easy answer would just be everything, and then we could wrap up and go home, right? But but more specifically, I definitely say breaking it down and understanding cultural intelligence based on those 4 capabilities has been really key to my own development. So taking that, 360 assessment, looking at the feedback from my peers, and then recognizing within each of the capabilities of drive, knowledge, strategy and action, how I can continue to develop. Through the resources that are provided, there are strategies. So getting like a whole book and having additional, strategies that I can look at and work through and help to create that action plan to continue to develop CQ has been essential. It wasn't just, me within my institution, but a group of us from our diversity, equity, and inclusion area, but also from our leadership institute that really is also, a key part of that education and leadership development and cultural intelligence for our organization and its employees. So having them be certified as well, and then having all of us be able to work on plans of action, work on how we put it into practice through educational opportunities, for our employees, but then also dialoguing together. I love the framework. It's easy to understand. It's based on Sternberg's multiple loci of intelligence theory. And it has just proven to be, a helpful resource. I think one of the things that I can remember from that training that I carry with me all the time is thinking ahead, planning ahead and planning for those multicultural interactions that you're going to have. So having that culturally humble mindset where you not only, like you and Ana both mentioned, think that there may be differences among people in worldview and backgrounds, but you expect people are going to be different. We expect our patients are going to be different in the terms of, their identities, in terms of their backgrounds, their understanding of, their own health, right? Their understanding of the diagnosis. We're a cancer institution. So even how they understand the cancer that they have been diagnosed with and understand the treatment around that, and then incorporating their cultural background needs into that as well. So thinking about their health, their spirituality, their fears, right? Stereotypes, things that they think about that have been associated with, healthcare, cancer care, and especially in communities that have been mistreated, that have been marginalized, that have been historically excluded and underserved. And so there's just a wealth of knowledge and information that's available, but I always break it down to really understanding those 4 capabilities that drive knowledge, strategy, and action, and how that's just been the cornerstone and the foundation piece of all of the CQ development that we've done as facilitators for ourselves, but then also putting that into practice through our educational programs for our employees.
Yeah, I think you said it well. And to take it back to something that Ana said early on this call, setting those quality standards give healthcare institutions a starting point, right? It's really hard to look at a blank sheet of paper and know what to write down first. But maybe if a starting point is there, we can start thinking about where to go next. And CQ or cultural intelligence can be similar to that. It gives us a way to benchmark, where are we today? What's our starting point? But then more importantly, what Devan said is it allows us to really start being intentional about where do we go. It's not just where are we today or what does it look like today, but it focuses a lot more on saying, and what can we do to develop? And what can we do to grow in our own cultural competencies? I love how you talked about humility. That's a big part of it. We have to admit we don't all know and we don't all get it right all the time, and that's okay. So I really like that. Ana, is there anything you want to add to that before I get into another question for you?
No, but I think underscoring the word humility is really important. We're dealing with a problem that many outcomes have been known for over a century. It's been well documented that women of color at birth are dying at multitudes of white women. A century, not 10 years ago, 15, a century. And so we have to be humble about that because we allowed that to happen. I've been in healthcare a long time. I was there too. That humility and that acceptance also should lead us to think about how easy it is to leave this problem as it used to be totally hidden.
Right.
And, that's one of the reasons why I argue, let's elevate it to quality and safety and let it live there. Let the accountability for that live there. Otherwise, it could be dropped and become hidden for another century. We've done it already for 100 years. We could do it for another 100.
Yeah. Well, I certainly hope that's not the case. That's part of the reason we want to be here today, to elevate these discussions and to make sure that we're continuing to talk about this. Ana, what else, in your opinion, can healthcare systems do to achieve health equity beyond the onboarding and the education?
Right. Of course, the onboarding and the education are essential, but I want to speak a little bit about accountability.
Sure.
Because when there's accountability, things get done. When there's measurement, things get done. And I think that this is one of the areas where, and it's not limited to healthcare equity, in all of quality, there's been a challenge to really, at the end of the day, who's accountable? But according to the law, it's the governing body. But we're not hearing cases every day where governing bodies are being challenged because they were not providing the right oversight. That's not happening. So what is it about the accountability model in healthcare that has to change so that we get the kind of traction and the improvements that really need to happen to address these issues, because they're enormous in the span of the problems that we have, in the complexity of the solutions that need to be brought to the front. It's not easy. No one has ever done this with 100% success, as you were saying. That's why we have to approach it with some humility. So I do think that we've got to re-examine how we hold ourselves accountable in healthcare for taking on not only healthcare equity, because I'm not proposing in any way to abandon other quality and healthcare issues that also need attention, especially since we learned during the pandemic that we had slippage in the improvements that we had made over the years. So again, what is it that we need in healthcare that's missing, that's not missing in the airline industry, that's not missing in the nuclear industry? What is it that we need to integrate and adapt into the accountability model, the governance model in healthcare to get us where we need to go? And I wish I had the answer to that. But I think asking that question, probing and getting more dialogue is a place to start.
Yeah, yeah. And, I'd like to further that question by asking you, let's just all hypothesize for a few minutes that we could move the needle and that systematic measures are taken and accountability is built in. What would we expect to see? What would the outcome be if we were able to solve for some of these challenges?
Unemployment for all of us. That's the truth. I mean, who would need us? And that would be a great reason to say, guess what? I don't need to go to work anymore. I can do something else, because quality and safety and all aspects of it are now at the optimal level. I think to achieve that, we really have to have some very honest conversations about what doesn't work and why it doesn't work. And most of the leaders in healthcare are not having those conversations because they are in a survival mode. We've got to get healthcare out of that survival mode and more in that we're building an infrastructure and institutions to meet needs of all people. And I think that, whether that's within our lifetime or not, but I think as long as an organization is trying to not let their bond ratings drop, as long as they're trying to staff the organization with the right number of qualified nurses, as long as they have battling with the unions, all of these things are the reality of what healthcare leaders are facing. I'm not putting them down or acting like they're not being responsible. Their challenges are competing with this.
Yeah.
And we've got to get to a point in time where we're no longer in competition with those things, and we can devote these very important issues the time and the talent that they need.
Yeah, that's really, really great insight. And I think that every industry experienced some sort of priority competition, right? But I think it's about continuing to talk about these things, continuing to push for this is just as important as the other priorities that we are trying to move the needle on. I really like how you answer that. Devan, do you have anything you want to add before I move into another question for you?
No, I think, Ana provided a really comprehensive kind of answer for it. One of the things that just stuck out in my mind, I'll say really quickly, when she talked about the competing, priorities of even being able to staff, right, our hospitals and our healthcare institutions. And I'm thinking specifically about nursing. And so if that is an issue, which we know we see nationwide, like not having enough qualified nurses, in positions in our hospitals, then what do we do about that? Earlier this morning, I saw an email from, our president, and the email was titled "The Transformation of Nursing." And it was step by step, like this is a plan for how we're going to address the issues that we're having within our institution around nursing. But what I loved about it is once I drilled down and read into it, part of the strategy for coming up with this plan included nurses, right? So there are a lot of times when, it goes back to what Ana said about, our communities too, not doing things to them, but working with them. I think the same is true where we see the challenges and the lack within our institutions, right? So if nursing, if we know that there are problems around staffing and other things related to quality and safety and other issues with nursing, we have to hear from the nurses, right? And they have to be a part of that plan and that strategy for how to transform their area of work and operations within our institution. So just something that I thought was a good connection point. And then there's training and onboarding and a lot that was a part of that transformation too, but just wanted to add that in.
Yeah, that's a really good example. I like that. And sort of this theme of working with, right, is so important. It's the idea of making sure that we have a variety of voices speaking to how to solve for whatever that challenge might be. Devan, I want to ask you a question. What can patients and even the larger communities expect to experience when their local healthcare institutions do invest in cultural competency or cultural intelligence or cultural humility education, or wait a minute, celebration of their staff? What will the community see?
I think they can definitely expect to feel more respected, right? And feel safer. And so going back to the issues of quality and safety and having that at the forefront, they can expect to be, more safe. There's a lot of fear around that, and for good reason. If we think about, where we have been historically, and again, things that have been allowed to happen, and approaching that with that humble mindset, like Ana mentioned before, but they can better expect that they're going to be cared for in a way that is culturally responsive and respectful, and that their needs and concerns are going to be addressed One of the things that we talk about within MD Anderson is not just treating, the disease, the cancer, right, the issue, but treating the whole person, and doing that and integrating body, mind, and spirit. So what does that mean to different individuals based on their backgrounds? What does that mean to their family members who are also an integral part of their care and an integral part of their health and them getting better? We have to take a look at and incorporate all of that. So on the reverse end, they can expect that they're going to be heard, that there are going to be conversations that are going to be had even before they go into, an operating room or a clinic or clinical area where they're going to meet with the physician, that people are going to be taking the time to collect information related to their identities, related to their, gender identity, expressions, sexual orientation, as well as, religious beliefs, opportunities for them to talk about what they don't know and what they might be concerned or afraid about. So really taking on that integrative approach from, a culturally intelligent standpoint and mindset, and making sure that it's not just going to be the nurse or the doctor or the social worker that I work with, but it's going to be every person that I come into contact with when I'm at that institution. They're all going to be knowledgeable about these things, and they're all going to be kind of operating from that framework and that mindset.
Yeah, very, very well put. And, I think that the real value is people want to be understood. They don't want to be looked at. They want to be understood. And to do that, we have to think a little bit beyond what we might see on the surface, how old someone is, what gender they are, right? It's going beyond those, as you already mentioned. What is their spiritual background? How does their religion affect how they may trust or not trust the advice they're being given? How does their family play into that? So I think, that ends the portion of some of our pre-planned questions for our panelists. I have a few questions from the audience that I'd like to pose to our panelists, but is there anything that either of you would like to do to sort of wrap up just the discussion that we've had today and the importance of these topics?
I'll just be honest and quickly say a lot of what, I just mentioned and what we talked about, and I think there was a question earlier about what does the investment look like. Definitely don't want to make this seem like it's easy to do, right? Because it isn't. When we talk about the onboarding, we talk about the education, we talk about how important it is to understand social determinants of health, to understand quality and safety, to look at the data to see where we are. This is all just a huge investment, on the part of the institution and the healthcare organizations. But it also has to come, from the top down. And I think Ana mentioned that at first. So it has to be something that even at the highest levels, governance, then we're looking at our executive leadership, senior leadership on down. So I say these things and I often smile when I say them. And I do that because it's so important and it's something that I'm so passionate about, but I don't want that smile to be confused with thinking that means it's easy. Yeah. Because it's not. It's a big investment and it's a lot of work. But I think going back to what Ana said, it starts with that quality and safety and looking at it from that standpoint and making sure that we are doing all that we can to be safe, to provide that quality care, and to not do harm.
Thank you so much. That was so well said. I have a question from the audience specifically for Ana, and I think this is sort of going to be a question that reinforces what Devan just shared and what you said earlier on the call. So here it is. I hear often when large healthcare organizations want to tighten the belt, such as in recent times, funding for DEI initiatives is one that's overlooked and chopped. You talked about this a little bit. Don't create a new function. So the question is, shouldn't it actually be the one that's funded more? And how can we educate our leaders in healthcare that DEI is one of the integral investments needed for successfully improving patient care?
Yeah, that's a great question. And wouldn't it be easy if the answer was yes? Oh, absolutely. You always have to fund DE&I. But, we did talk about the competing priorities. And I think one of the ways of losing your audience on this topic is to not being sensitive to those competing priorities. You know, Devan said, don't confuse my smile. My smile is to always invite the opposing view, because if I don't have you in a dialogue, we've lost this battle. And part of staying in dialogue and keeping leadership engaged is to be able to appreciate that there are those competing, and that perhaps this is not the year when you can't staff your critical care unit to invest in some program that, is really important. I think that practicality has to come to the table, but that practicality does not mean that you compromise to the point where you don't make progress. Progress can be made by doing a lot of things that don't necessarily require external funding. Progress can be made by the fact that you're just beginning to collect data and looking at problems that have gone hidden, and that you start to have that conversation. So I do think that having a bit of, you have to have empathy for the marginalized community, but you have to also have some empathy and understanding for the fact that this is a very tough business to run in today's world. And we can't stop being business people. Speaking of business, one of the areas that has to be developed as we articulate the need to address healthcare equity is the ROI, the return of investment. What costs more, preventing a disease or treating its complications? 40% of the national business in Blue Cross and Blue Shield is risk contracting. That means 40% nationally, organizations are better off taking care of the illness before it happens, or early detection and preventing its complications, because it is financially better for the organization. So we have to soon start talking from health equity is a morally right thing to do. It's equality and safety, but guess what? It's the financially right thing to do. And we have to build those cases to bring the chief financial officers, to bring the business case to the discussion around why it's so important to do healthcare equity, even in the presence of competing priorities.
That was brilliant. You're exactly right. It's building the business case. We can't ignore one issue in favor of another, and not having the ability to empathize, as you mentioned, both on the community side, but also on the challenges that the leaders are experiencing running healthcare institutions. I like how you addressed both sides of that coin. I now have a question from the audience specific for Devan. And Devan, in prep for our webinar today, we knew this question would come up given the institution that you work for and where you're located. So it did come up in the chat. So in Texas, there are a lot of new challenges coming in recent months to the DEI space, as many of us, especially our North American audience, knows. The question to you is, and please share to whatever extent is appropriate, okay? So how is your institution, MD Anderson, specifically addressing these issues given the recent legislation?
Okay. Whew, here we go. So again, I think most people, especially, our colleagues across North America, are aware of what's happening, politically, and how it's impacting a lot of the work within diversity, equity, and inclusion across the state. We are a state institution, so one of the things that we quite naturally have to do is look to our system, to our University of Texas system, their governance, and then to our state for guidance. So basic guidance and compliance with the law is going to be one thing. But I will also say, and I think I mentioned this earlier, we're going back to our mission and to our core values that have to do with caring and have to do with safety, as well as our emphasis on inclusion and being, culturally intelligent. And so we're not going to lose sight of that. Ana mentioned very early on about infrastructure. So thinking about not just having things that are separate programs and initiatives, but when you really embed it into all of the work within the institution, it's embedded into the culture. We can't take that out. And I'll say that because we have been working for years, well beyond my time at MD Anderson, to embed it, into the culture. So even if you do not see, a diversity, equity, and inclusion office, so to speak, the work is still going to be there, and it's going to continue because it has been embedded so well in ways that it'll continue in terms of prevention. And that was one of the things that Ana just mentioned that's really important. Patient education, patient services, our research enterprise, as well as our clinical enterprise. And so we'll continue, the work towards health equity in that way.
Well said. Ana, is there anything you would add?
No, I have admiration for Devan and the work that MD Anderson has done. They should be commended. The other thing is, I think we're all citizens and we all live in a political environment outside of our work, and it's important to stay, to do our civil duty and, to participate in the political process, the election process, and make sure that your values and your preferences are that you vote that way. And so voting is very important, and beyond voting, participating in the political process.
Yeah. Well, thank you for our audience for asking those questions of our panelists. I think our discussion today was so rich and it was so eye-opening for me. And I know that our audience also really appreciates the experiences you both have shared, the fact that you're both bringing a different perspective to the conversation given your background. So thank you everybody for participating today. For those of you who registered for our event but were unable to attend, we will follow up with a recording of this session. Feel free to watch it after the fact and share it with anybody who you think would like to see conversations and solutions to some of the challenges we discussed today. So with that, we'll go ahead and wrap for the day. Thanks again to our panelists.
Thank you so much. I really enjoyed the
Bye-bye.
opportunity.
Bye.